Hi, I'm here to discuss with you the second part of heart failure in a skilled nursing home. We discussed last time about congestive heart failure, pathophysiology, type of the heart failure. We also discussed about symptoms of the heart failure. That was the basic fundamental knowledge about the heart failure. In this review, as a part two, we're going to review the symptoms of congestive heart failure exacerbation, one of the main causes that actually make the residents of a skilled nursing home or even the home health to be transferred to emergency room and hospital. In the next videos, we're going to talk about pharmacological intervention related to skilled nursing home cases with the heart failure. And also we're going to discuss about how we can build a heart failure program. Be with me and we're going to discuss more about heart failure today. The second things that we discuss is about two type of heart failure that we have. We discuss about the first type of heart failure is heart failure reduced ejection fraction or HFrEF. We discuss about it. This is more systolic heart failure, means that technically we have more contractility issue. Please review the session 1 or video 1 about the part 1 of the heart failure if you still have a problem to understand that. And the second type of the heart failure is HFpEF or heart failure with the preserved ejection fraction. This kind of heart failure we have preserved ejection fraction, like means more than 40%, but this is more related to hypertrophy of the left ventricle. Remember, that's not a problem with contractility, it's a space problem. But even the ejection fraction is actually preserved in both heart failure, no matter what's the cause. The cardiac output, it's going to drop, means that there is less blood going to vital organs, including kidneys or brain or even the lower extremity. And this is why we have symptoms of the heart failure in both. The other things that we have is the left versus the right heart failure. We discuss about it that when we have the left heart failure, technically the fluid start to back up in the lungs, and when we have a right heart failure, we have the fluid starting to back up in the veins. And this is exactly the difference between that. That's why when we have left heart failure, this is what we're expecting to see. We have more fluid in the airways because the fluid backed up to the lung. And this is why we have pleural effusion. And as a consequence of that, we have pulmonary edema, which is, again, a lot of fluid goes to the interstitial space of the lung. And as we discussed, fluid in the lungs means either pleural effusion or we have pulmonary edema. When we have right side heart failure, we discuss about the circulation backed up in the veins, means that our major veins get dilated. Like, for example, one of the best one that you can see is the neck, is a jugular vein. You can easily see when it gets extremely dilated in your patients, in your residents at a skilled nursing home. Easily you can watch it on the neck area. The other sign that we all familiar with is a worsening of lower extremities, which is technically what we call edema. And when it gets worse, we call it peeling edema. And then we grade that 1+, 2+, trace edema. But technically for people with heart failure, they have significant edema and we can easily see that. The other things, when the vein get congested, it can happen in intra organs, like for example, a liver or a spleen can have the venous congestion. And what we have, we have hepatomegaly, we have a splenomegaly, we have elevated liver enzyme. We can see all of them in person with the heart failure situation as we discuss about it. That any kind of this can happen. But technically, what is the symptoms in both left side and right side heart failure? And I wanted to answer you that because all of the heart failure, because of low cardiac output, the person get less blood to the muscles. That means one of the major signs that we see, and also the patient even subjectively complain, is about fatigue, generalized fatigue, feeling extremely tired. I don't have energy to do anything. And the other symptoms that we're going to discuss a little bit more is a shortness shortness of breath, that can be subjective, can be also objective. And the other symptoms that we can see is all about chest pain. Is that chest pain can be chronic chest pain, chest tightness. Sometimes patients complain about it. Sometimes always they have some chest tightness, but new onset or worsening of the chronic chest pain. But again, the symptoms can happen in both situations. But one of the major things that actually cause majority of transfer of the residents from skilled nursing home to the emergency room is actually congestive heart failure exacerbation, or what we call acute decompensated heart failure, one of the major conditions that happen in these people. What happens is that imagine that you have a resident that already has the heart failure, but now what is happening that the heart failure is getting the symptoms getting worse, which is a chronic heart failure problem. Like for example, if they have edema, the edema is getting worse. If they have shortness of breath, the shortness of breath getting worse. If they have feeling fatigue, the fatigue is getting worse. That's technically is a worsening sign and symptoms of heart, or it can be completely new case of acute decompensated heart failure with all the spectrum of the symptoms of the heart failure. But that's going to be the main cause of the readmissions or even transfer of this residents back to the hospital. When we talk about heart failure, it is important that we understand what do we monitor for patients with heart failure in a skilled nursing home. And these are the items that we always do. This is going to be the principle of any heart failure program in the clinical side, which means the nurses on the floor. And that means monitor weight, dietary control, and dietary control is going to be extremely important because we talk about salt, we talk about the salt restriction, and we know the part of that goes to the dietitians at the skilled nursing home, the part of that goes to the kitchen at the skilled nursing home, but a part of that's going to go to education of the patient, or education, we need to educate also the family members to make sure that they are following the direction that you are instructing to do. For example, if your patient's supposed to be on restricted salt diet, then if imagine that family members bring their loved one salt every weekend, or salty food, salty crackers, or food from outside from restaurant, most of them they're very salty, and they take this salt, then you're never able to have or compliant or follow, like for example 1.5 grams salt total salt in diet, or 2 grams, depends on what you put the order on. But technically it is important, the dietary control, it's a really important part, and the beginning of admission needs to happen, needs to be communicated with the family. Everybody should be involved with that to have a common a program, to common instructions that everybody follow that. The vital signs I will explain to you in a second, so how it is important, the most important part of the assessment, and the clinical assessment, which is technically symptoms that the patient subjectively telling you, and objectively you also watch that. When we talk about weight monitoring, this is an important things that I want to say. A part of the major part of any heart failure program is actually a baseline weight first. And that's the thing that I really wanted to discuss a little bit about it, because a lot of time I've seen the people, they write the hospital weight as the baseline weight. This is absolutely wrong. And I will tell you what's the reason for that. A lot of time when the patient discharged from hospital, the weight that they putting at the discharge note or the transfer note is not an actual weight of the patients at the time of discharge. That can be weight that the patient had in the emergency room. And then during the hospitalization, they may treat the pneumonia or urosepsis, they give IV fluid, and the patients actually gain a lot of weight and then come to the skilled nursing home with the new weight that you're not aware of that, and the hospital never actually put the new weight there, and then technically you see, oh wow, the patient has a significant weight gain and from the time of hospitalization, and that makes you worry about it. But technically this is not the accurate weight. The weight is accurate that you measure it. You, in the first 24 hours of admissions of every single patient at a skilled nursing home, you need to weigh them and measure their weight. and document. And this is going to be your baseline weight, and you're going to monitor from there. The other things is a daily weight. With technically, daily weight is extremely important because in the daily weight we do it, and the most important thing is going to be the same scale and the same clothes. And the same clothes is so important because a lot of time you weigh the residents the day before with the boots, with the 2 jackets on, with a blanket at the same time, and the next day is only with gown. That doesn't work that way. And the other thing is to make sure the scale you have in the facility is very well calibrated, is an accurate one. You can do the testing for that scale to make sure that's working well. Now, what is important in a skilled nursing home, and even the patients on a home health, is technically the rule of the 3 days and 7 days. 3 pounds in 3 days, 5 pounds in 7 days. It's so important. Like for example, if you have a residence that on Monday to Tuesday, we have weight gain of 1 pound. That's really not important, but we need to pay attention to it, because if we have the weight on Wednesday, and then on Thursday and Friday we have increased the weight level from to 4 pounds and 5 pounds, then this is the sign of CHF exacerbation. Then we need to go do the assessment. We need to evaluate residents at the bedside, looking at edema, auscultate, do asking question about, which we had in on the session 1 about shortness of breath, chest pain, and many other symptoms, and then technically evaluate the residents to see if there's any difference in the clinical manifestation or not. But this is important. But if there is, then we are in the CHF exacerbation and we need to do an action. And of course, the other things that we always see with the weight is edema. Edema means the fluid retention, and whenever the weight is getting worse, means that we definitely have the worsening of edema. Vital sign. I can't tell you how important it is to have a right vital sign for patients. And this is one of the things that I'm always remind everyone to do it and think about it, because the vital sign is the most crucial part of this plan. And this is so important to understand, because that means that you need to really rely on your CNAs to give you a correct vital sign. You have to also instruct to your CNAs to make sure that for any heart failure patients that they have, they are paying attention to the vital sign. Make sure that they do not give up if they're not able to get one of the measure. All these elements is so important for you: heart rate, respiratory rate, blood pressure, and O2 saturation. And I wanted to tell you that heart rate is one of the most crucial elements of the vital sign, especially when the heart is fast. And we discussed about in the session 1, when the heart is fast means that you technically, because you need more oxygen, that's why the heart tries to compensate. That's why it's beating faster. And when the respiratory rate is fast, this is also compensatory. The chief of commander, which is your brain, is telling your lungs that please breathe faster because I have a problem with the oxygen. That's why respiratory rate is going to be higher. And that's technically any of this: heart rate more than 100, or bradycardia less than 50, respiratory rate above 30 or less than 10, or even the blood pressure, especially even the blood pressure low. That's a very, very worrisome sign, because that means that really we have decompensated heart failure. That kind of patient, usually they need to be hospitalized, but it really depends on the other clinical picture. And we just wanted to again emphasize how much the vital sign is important, or O2 saturation, which is less than 90%. That's why many times when I talk about vital sign, many of us only focus on oxygen saturation. That's not correct. We need to really think about all elements of vital signs in patients. And what are the symptoms technically when you, for example, when you look at the symptoms, we talk about a worsening of shortness of breath. And one of the things is, the other symptoms is orthopnea. We talk about it in the first session. Orthopnea means that when the resident's lying flat, the shortness of breath will start. And why is that? Because left side lung left side heart failure, back up the fluid in the lung, and that's why you have more shortness of breath when you're lying flat. And that can be happen in the night shift. The night shift can actually see that, and that's going to be the problematic. And again, when the fluid's going to build up, it can goes to the peritoneal area, and as I say, the venous congestion, and you can have ascites. The size of the abdomen is going to be increased, and very discomfort for that. We talk about worsening of edema. The worsening of edema can happen in the legs, extending to the upper level, extended to genital area, come all the way to abdominal area that we discussed. And definitely the person is going to have less motivation to eat. And one of the main reasons, because, for example, you see worsening of dizziness, or they have confusion or sadness. And the main reason, because the brain does not get enough blood flow. When the brain does not get enough blood flow, that's a problematic part, because then brain doesn't need calories. That's why it's eating less. It's more confused. It's altered mental status. These are all can be the symptoms and sign of the heart failure exacerbation. And that's just so important to understand. Any patient with heart failure, that's something we need to know. And again, the other things can be the chest pain. As we discussed, the new onset of chest pain or worsening of the chronic chest pain can be a sign or symptoms of congestive heart failure exacerbation. As we discussed, the crackles in the lungs can be very problematic. One of the things that means that we have a CHF exacerbation is a problematic situation. But what it needs is your stethoscope. You need to put it on, go to the bedside, put it on the chest, and listen to the sounds of the fluid in the pleural area like this. And then, but the other side, you can also have the wheezing sound. Wheezing sounds happen when the air passes through the narrow airway, and is usually noticeable when they exhale or breathing out, but also can happen in breathing in as well, or inhale. Something like that is kind of like high-pitched musical sound that you can listen at. And then you can have a shortness of breath, which is can be subjective and objective. And when we talk about the subjective and objective for shortness of breath, the subjective is the residents by himself or herself telling you that today, when I walk to the half of the stations or nursing the station, I get easily shortness of breath. Or if I go to the bathroom, I have a hard time. But objectively, you can notice that the rehab team, or if the patient is getting physical therapy, occupational therapy, it's going to be the best people can tell you that this resident has significantly reduced function, and that's something that you can think about it. And always, either can be new or worsening from the baseline. Remember, the potential cause of the heart failure exacerbation can be multiple reasons. But one of the major reasons that you can think, and you can think about the residents, why my residents got worsening of heart failure, is any new medication has been started for that resident, especially the medication like non-steroidal anti-inflammatory drug, NSAID, ibuprofen, naproxen, any of them is this medication, meloxicam, any kind of this medication can worsening the heart failure. Remember that. Or even some of the cardiac medication like a beta blocker. If it's a new beta blocker is a good medication, is a bad medication. It can be very helpful, it can be also bad. It depends on the type of the heart failure. For example, if it's a half RAF or half PAF is a different scenario that we can discuss about it in the pharmacological part in another session. But remember that. The other things that can happen a lot to the cause of the heart failure exacerbation is fluid. Means that you recently or team recently give the fluid to the resident because, for example, was dehydrated, or you wanted to had an infection and you give IV fluid. Technically, anybody got IV fluid, it can happen to have a CHF exacerbation in the next day. And that's something you need to remember. We talk about the salt intake. It's a very, very important thing. That is one of the most problematic situation in any person with heart failure. Either it can happen through the diet that we provide or the family members providing from outside, or sometimes residents ordering the food with the delivery situation without that that. And that's very difficult. That's why for heart failure residents, you kind of should have a discipline, and you need to be seriously talking to residents, explaining to them why the salt intake is important and restriction of the salt is extremely important for their well-being. They need to be educated. Family needs to be educated. The other cause of the heart failure exacerbation can be infection, especially lung infection. If anybody gets pneumonia, they can easily get heart failure exacerbation. That's something we need to know that. And at the end, as a non-compliant with the treatment, either refusing medications or refusing the following instruction related to dietary restriction, they can cause that. But can we do really anything in the facility to help with the CHF? We can do a lot. Actually, many of the CHF patients, they really don't need to be transferred to emergency room and the hospital. With the right action, if you do the assessment that we discussed, if you understand the heart failure exacerbation symptoms, notify MD, make a plan together, do the good monitoring, many of these patients can stay in a skilled nursing home without transfer. Look, for example, one of the basic protocols is always diuretic adjustment. Is the patient needs the diuretic or being on a diuretic and you need to increase the dose. Definitely you need to monitor the urinary output to see if your diuretic is working. On the other side, you also continue to measure the weight of the resident to make sure that your diuretic is helpful, and also you measure the urine output to see if they are able to urinate more. Some of the medications we will discuss about it. These are a lot of new medications that you can use to kind of helping with the cardiac situation. That needs to be coordinated with the providers and MD to trying the new medications can help with the heart failure. Monitoring the kidney function is extremely important, that we need to do that to see that with the use of the diuretic, we're not making more problem with the kidney. We can have some rise, kind of like a rise in the creatinine level at the beginning of the using the diuretic. That's okay, but then we have to also keep monitoring to make sure it's not going to get worse. So some of the residents, they need oxygen as needed basis. We provide for them. And again, the most important part, it's the goals of care discussion, especially for the residents that they have a very advanced heart failure. It is important that as a team, discuss with the physician, discuss with the family, really have a realistic expectation. And this part is actually should happen in a skilled nursing home. Sometimes you may ask the specialist or cardiologist to be part of the goals of care discussion. That can help a lot to really reduce the rehospitalization. And we focus on the symptomatic management in a skilled nursing home without transitioning patients back and forth in the ambulance to emergency room, back to the facility. And these are the things that is important. That's why heart failure, it's really teamwork, and then we need to work together for that. Again, the key point that about this is all the things that we discussed today is about preventing heart failure exacerbation from transfer to the emergency room in the hospital. And that can happen. Again, as I said, assessment, identify the situation can happen. And as I explained to you, everything is related on early detection. I believe it very, again, strongly about this. And the main reason for that, because heart failure exacerbation is not happening in 1 hour. It's not happening in one shift. Usually patients or residents have the symptoms days or hours before. And unless if it's very severe, like for example, septic situation happens suddenly and then goes to the heart failure exacerbation. And even in that situation, the infection symptoms can happen days before. I will say that somebody in like half an hour go to acute decompensated heart failure. It can happen, but it's not common. Most of the time, there are symptoms that are happening the days before, and we do not detect that. We do not do a good assessment. we not do a good monitoring, we don't do a good communication, and this is why later the residents goes to the CHF exacerbation. If we are able to do early detection, we're able to technically solve many of the heart failure problems in appropriate time. And as I said, the beauty of the work of the nursing is assessment. Is everything about assessment, head to toe assessment, is everything about every symptoms in the skilled nursing is all about assessment. Same thing for heart failure. All depends on your assessment to what you do. And the last thing is important is a communication. The communication with the team, with the MDs, with the supervisor, with the assistant director of nursing, or the director of nursing, as a team together, do communication with dietitian, communication with social worker, asking for interdisciplinary team meeting. Many of these things has actually happened in the heart failure patient. That's why we need to do that. I wanted to thank you so much for listening to this presentation. And in the next sessions, we're going to discuss more about the pharmacological and also build the heart failure program in the facility.